After triage, we're generally going to be taking people to a treatment area. This is where we can have all of our survivors in one spot if they're being taken out of a building, or if we have a casualty collection point where we have ambulances coming to pick up injuries. This is the medical treatment area. This is where you're going to have a medical response team that is doing hands-on, doing reassessment. This is where I'm a little upset about the course of the 2019 CERT rewrite. They've taken out some of the ICS language. They call it a medical team area or medical treatment leader, medical unit leader, Tarp leader. Everything's a leader. That is not the terminology used in ICS. You're generally going to have a medical unit. You're going to have a treatment group, a triage group, a transport group. There's groups underneath the unit. Those group leaders are supervisors, group supervisors. So if you set up TARPs, you're going to have your immediate, delayed, and walking wounded TARPs. You're going to have a treatment group supervisor there with a scribe and a radio communicator. That core leadership team, again, going back to the three. That team leader, the scribe, and the radio communicator. The treatment group supervisor, that command team, is overseeing all three TARPs, the red, the yellow, and the green. They're going to be tracking incoming, and before they get assigned to a TARP, they're going to re-triage. They might have been triaged in the field as yellow, but as they've been transported over to the treatment area, they get there, that group supervisor is going to look them over and go, no, this person is immediate. Take them over to the red TARP. A lot of our drills we've done don't have this element. They just have the transport teams bringing people from the crash site or whatever and dumping them on TARPs. This treatment group supervisor provides a very important role as the initial re-triage as they get to the treatment area. And it's going to eliminate a lot of the problems of the mistriage in the field. Or things have changed to that victim or survivor and they have been re-triaged to a more appropriate TARP. The scribe there is going to be tracking the outgoing and status changes, so as well as the incoming. So as you have someone come in, that transport team is going to say, you know, this is a 35-year-old male, immediate. The treatment group supervisor is going to re-triage and go, correct, immediate, take them over to the red TARP. The scribe is going to write down 35-year-old male and mark them into the red category. This is important because you need to know how many survivors you have. You need to have patient accountability. If you have 15 people on the list and you recount and you only have 14, you lost somebody. Somebody wandered away or something happened, and that's not good, to say the least. Your radio communicator is going to be updating staging. And if you have a transport team that's taking anybody to definitive care, they're going to be in contact with them as well. This is critical. Staging area is blind. They don't know how bad things are out there. It's up to that radio communicator to constantly update them and provide them information. We now have 15 immediate, 3 delayed, and 5 walking wounded. 5 minutes later, we now have 20 immediate, 5 delayed, 15 walking wounded. On each TARP, you're going to have a TARP leader and a scribe. And the TARP leader's job is to be in charge of the overall TARP. They're making sure that nobody gets up and wanders away. They're making sure the first aiders or the rescuers on the TARP are reassessing people and not getting stuck doing something and ignoring someone. They're going to be visually reassessing survivors. If you see somebody getting worse, bring it to someone's attention, make sure that they get checked out and treated, or make sure that they intervene before that worsening progression becomes life-threatening. And if you're, say, on the yellow TARP and you see somebody that now needs to go to the immediate TARP or the red TARP, you're going to request that status change and you're going to take it to the group supervisor, the treatment group supervisor. Let them know, hey, I have someone here on the delayed tarp, they need to go to immediate, and this is why. And make sure that gets updated, make sure everybody is talking to each other so you don't have people moving between tarps and nobody has accountability on them. We had 5 people on the yellow tarp, now there's 4. Did this person get up and walk away? Or did this person get moved over to the red tarp and nobody told anybody about it? This is generally what a tarp treatment area is going to look like. You're going to have the immediate tarp, the delayed tarp, and the walking wounded. You want to make sure that everybody brings anybody into this area through one location and they get checked out. If you have people, if this is open and you have people coming from every single direction, it's going to be utter chaos and impossible to control. You won't know if people are coming or going. You won't know if you have survivors who are getting up and walking away. You don't know anything that's going on, and it's very difficult to control this. But if you say everybody comes through here, or this is in an area that's fenced off and there's only one entrance, it's much better, easier to control this situation. Your treatment group supervisor, scribe, and radio communications person are going to be pretty much center, closer to the immediate and delayed tarps. The walking wounded, sometimes you might not even have people on there. They're sitting there just to keep them in one place. It depends on your resources. But you want to make sure that you're keeping an eye on that walking wounded tarp, because if anybody gets worse, they need to be escalated, moved over to the delayed tarp. You want to catch that before you have someone who's not breathing on the walking wounded tarp. Generally, you're going to be consistent on your languaging. If you're going to choose to use the color system, green, yellow, and red, or red, yellow, and green, always use those and stay with that system. If you're talking about immediate, delayed, and the term is minor, I personally don't like minor. Minor is ambiguous to me. I don't know if they're talking about someone who's walking wounded or if they're talking about someone who's under 18. So I personally try and strive to use immediate, delayed, and walking wounded. It's better languaging in my opinion. Other people may disagree with me. Or we're going to stick to green, yellow, and red. Everybody knows what those. The tarp leaders are going to be on the side of their tarp. They're generally not going to be getting onto the tarp unless something has gone wrong. They want to maintain that situational awareness, the big picture, whatever is on their tarp. And these could be 30 by 30 feet tarps with 15 people on them. You need to have that big picture. If you're in the middle of it, it's much more difficult to understand what's going on and keep a full picture. And that scribe there is going to help control that chaos. Document, document, document. Make sure I've got 15 people on this tarp. There are still 15 people on this tarp. There's not now 14. On the tarps themselves, you're going to have tarp rescue repairs. And again, CERTs should be doing everything in pairs. And again, that hands-on person and that hands-off person. Now, I understand fully we might not have all the resources in the world. Ideally, we should have pairs. Realistically, you might be the only person on the red tarp and you're a first aider. Good luck to you if you have 15 survivors. But if you're paired up with somebody, they're going to help keep you sane. Whether or not having 2 individual rescuers working a red tarp with 15 survivors is better or worse than having a pair, one hands on, one hands off, I'm going to leave that up to you. It's going to be situational dependent, but I can tell you that if you're the one person working on 7 victims or survivors versus 2 people working on 15, 7 people is going to be overwhelming. You're not going to know what that person's condition was 5 minutes ago because you've already moved on to the next one. That scribe there is going to help keep sanity, keep you sane, keep track of what's going on. I'm going to leave it up to you how you want to do this. When the survivor arrives at the tarp, you're going to re-triage. Make sure that the transport team or the triage team, the transport team, and even your group supervisor got it right. Someone shows up on the yellow tarp and they have bruising behind their ears and under their eyes. They need to go to the red tarp. They might not have other symptoms, but that is called battle signs. They have some sort of brain injury, and this is not something that should be on the yellow tarp. And the more medically trained people are going to be able to pick this up a lot easier. It's simply how it is. When they're on your tarp, you want to assess them. If they're stable, and reassess them. If they're stable, you're checking them every 15 minutes. That might be hard if you're the only one there and there's 15 survivors. It's certainly going to be a lot harder when you realize that if they're not stable, you have to reassess them every 5 minutes. And if you're the only one there and there's 15 survivors, that 5 minutes is going to be very, very difficult to do. You'll pretty much have to reassess every single patient and then start over again. No treating. But as a good rule of thumb, reassess every 5 minutes if they're unstable. You're checking for life-threatening injuries or changes in their condition. Do they still have a good open and clear airway? Are they breathing properly? Do they have good skin perfusion? Those RPMs. And then, if you have time, you should be doing a detailed assessment. That's the head to toe. You are starting at the head of the body, you moving your way down, checking for any additional injuries, anything that was missed, anything that you can treat. Generally, you want to complete the head to toe before you treat, but if you find something life-threatening, this person has blood pouring out of a hole in the back of their body, and it's starting to pool. I need to do something about this now. I'm not going to wait till I get to the feet and then go back. Again, one rescuer hands-on, one rescuer hands-off. That person should be subscribing and assisting, handing supplies out of the medical bag. Typical interventions or treatments at the TARP. When you're placing people on the TARP, you want to be organized about it. And this is where that TARP leader is going to be critical. You're telling people where to put this person, this survivor. You want to have them head to toe, head to toe, head to toe. And the main reason for this is if you're starting as a rescuer, you're starting at one person's head, moving down to their toes, and you're right at the head of the next person, and you're able to progress through. Additionally, if you have people who are head to head and one person's vomits, it tends to be a cascading effect. One person vomits, the next person vomits, the next person vomits. And unfortunately, with trauma, with injuries, people will vomit. So if people are head to toe, then it's less likely to have such a cascading effect as if they were head to head. That is going to be bad. That will get very ugly very fast. If you encounter bleeding, you're going to try and stop it with direct pressure. If you can't stop it with direct pressure and it seems appropriate, use a pressure bandage. If it doesn't seem appropriate, like they're gushing bright red blood, you want to put a tourniquet on it. The old teaching, and this is, I still hear it occasionally, is if you put a tourniquet on someone's limb, they will lose the limb below the tourniquet. That is not the current training. That is not the current teaching. What is relevant, though, is if you don't stop the person from bleeding, they will bleed out. All bleeding stops eventually. You can either stop it yourself, either through direct pressure or pressure bandage or tourniquet, or that person will not have enough blood in their body to continue pumping blood, and they will stop bleeding. Naturally is probably the wrong term, but they will stop bleeding in a bad way. So tourniquets are important to use. This is not to talk about tourniquets. You need to get trained on how to use a tourniquet properly before you apply a tourniquet, but it's good training. I recommend, if you haven't taken the Stop the Bleed class, definitely take that. Definitely take any advanced training you can get. Sprains, strains, dislocation, fractures. You're generally going to splint these in place. By splinting a strain, or dislocation, you're taking pressure off of it. You're using the splint to take pressure off the injury, and it's going to help with pain. You're not going to try and adjust it. If I used the example of a 90-degree turn in a forearm before. you're not going to straighten that out. You can cause more damage by doing that. What you're going to try and do is put a splint in place to keep that injury stable. But before you do that, you need to check, it's called PMS or CMTS. I like the term CMTS better than PMS. PMS stands for pulse, motor or motion, and sensory. Unless you know what you're doing, it takes a little bit too long to check for a pulse. I like CMTS better because I think it falls in line better with RPM. You're checking the color. That's the skin perfusion. How quickly does the blood flow return if you pinch the nail bed? Motor function. Can they wiggle their fingers or toes? Temperature. Are their fingers or toes warm and dry? Sensation. If you touch them, do they feel it? If the answer is yes before you splint them, and then you reassess them after, and the answer is no, they can't feel it, or the skin is turning blue, you've cut off circulation and need to take that splint off and make sure that circulation returns, and then try the splint again. Or worst case scenario, don't cause more harm than you're trying to fix. Open fractures, there's not too much we can do about this in the field. Cover it with a sterile dressing. Keep some debris out of it. Shock. Shock is a killer. People who have trauma will generally develop into shock. Lie them flat, keep them covered and warm. What's happening with shock is that the body is not able to compensate. It's pulling blood flow away from the extremities, trying to keep the body alive. And so you're going to notice this in the fingers and toes first. They're going to get cold, they're going to become a little bluish, and they're not going to have as good sensation and color and skin temp perfusion. The raising of the feet generally is not used in treating shock as much anymore. I don't think it hurts. If you have something that you could put under their feet, go ahead and do it. I don't know if the 2019 CERT training teaches putting something under someone's feet for shock anymore. This one's critical. Maintain a patent airway. You want to keep your survivor breathing. You want to keep their airway clear. There's been mass victim incidents where people have died because they were left alone. They vomited, they aspirated, and their airway was no longer clear. They couldn't breathe, they died. So if you need to leave your survivor alone for any amount of time, and there's any risk, you want to try and put them in the recovery position or the left lateral recumbent position. And they do teach this in CERT. You're going to roll them on their side, assuming there's no spinal risk of spinal injury. You're going to put one arm behind their head and rest their head, cradle that on their arm, and the other arm is going to drape over the front of their body, kind of like this. This is not a medical class. I'm not teaching you how to do this. This is a good way to keep their airway open and clear. If they vomit, they will vomit or drool, or if they're bleeding out of their mouth, it'll come out of their mouth and roll down onto the ground. Instead, if they're on their back, there's no place for this to go. It will back up, it will occlude the airway, and your survivor will no longer be a survivor. When someone comes to pick up, take the survivor off your hands. You're transferring care, hopefully to EMS. Hopefully the fire department or an ambulance company is there to take this person to definitive care. You're going to give them their name, and you never give a patient's name over the radio. This is a handoff in person. Age, sex, time they arrived, their chief complaint, and whatever treatments or interventions you gave them. This is information that is going to go to the hospital with the survivor and is going to be needed by the emergency medical department. And then you're going to let your chain of command know. Generally speaking, it's the group leader who's going to be overseeing the handoff to EMS, and then their radio operator is going to let the staging area know we now have 14 immediates. One has been transported to definitive care.